So good afternoon, respected delegates. Myself Dr. Ankita. I am going to present on the topic effect of clear corneal arcuate incisions for the correction of astigmatism using Alcon-Varian nomogram. 40% of patients undergoing cataract surgery have astigmatism up to 1 diopter and 70% have more than 0.5 diopter. So to tackle this low to moderate astigmatism, we have few options. Toric IOL and femtosecond laser assisted arcuate keratotomy are a bit expensive. The limbal relaxing incision needs a diamond plate, which is again expensive. The opposite clear corneal incision is a slightly unpredictable outcome. So we are left with two options. One is steepest meridian clear corneal incision, another is paired clear corneal arcuate incision. There are some studies which show a better result with a paired incision in comparison to a single incision. So the purpose of my study is to evaluate the efficacy of paired clear corneal arcuate incisions for the correction of mild to moderate corneal astigmatism during phacoemulsification using Alcon-Varian nomogram and compare the results with the demographically matched control group. This was a retrospective study from January to June 2024. Inclusion criteria was expected post-operative refraction with an astigmatism between 0.5 to 1.5 diopter and central corneal thickness between 470 to 550. The exclusion criteria was keratometry values more than 48 diopter and any corneal surface epithelial defect and posterior segment consideration.
That's
why I was like,
your moderators, who is judging this next session?
Height and arc length in the study group. In this, the incision was given up to 90% depth of the cornea between 7 to 8 mm diameter circles centered over the corneal vortex. We divided the study group into two groups based on the central corneal thickness. In patients having more than 500 micron thickness, we used a 600 micron guarded knife, and in patients with less than 500, we used a 550 micron guarded knife. The keratometry was recorded preoperatively and at 1 and 6 weeks postoperatively. The uncorrected visual acuity, best corrected visual acuity and acceptance were recorded at 1 week and 6 weeks follow-up. So coming to results, we studied the demographic data of both the groups like gender, age, CCT and preoperative astigmatism, and both of them were similar in both the groups. In the study group, the preoperative astigmatism less than 0.5 was 2.7%, which increased to 70% at 6 weeks postoperatively, but in the control group it was only 15.8%. This is the box and whisker pattern which shows a decreasing trend of astigmatism in the study group. In comparison, in the control group it remains almost similar. So we could make 52% of our patients in the study group happy with no spectacle for a distance, but in the control group it was 21%. The uncorrected visual acuity of 6/6 was there in 48% of our patients by 6 weeks post-op. In comparison, only 8% in the control group. The median astigmatism in the study group, it decreased from 0.86 to 0.44 at first week and again to 0.41 in the 6 weeks, but in the control group it remained almost similar. We again divided both the study population into two groups depending on the CCT, but they gave us a similar result showing that central corneal thickness does not affect the outcome of arcuate incisions. I could find two studies similar to our study. So in our there is also similar decrease in the K values post-operatively. The sample in our study the K value was 0.99, but in Fall et al. And Yep et al. It was a higher K value. In our study at 6 weeks the decrease was 54%, in Fall et al. It was 37% and in Yep et al. It was 52%. The sample size in these studies were very less compared to our study, which had a 375 sample size, and our study compares with a demographically similar group which was not present in these studies. So in conclusion, a significant number of patients have preoperative astigmatism but cannot afford its correction. A paired arcuate clear corneal incision with a simple guarded knife using nomogram in Varian markerless imaging system is a cost-effective method of correcting the astigmatism and giving emetopic vision to more than 85% of the patients. These are my references. Thank you.
So can you, earlier there used to be the section, now we are giving temporal, depending on this, which side, suppose the vertical is steep,
Yes, sir.
Where you will give the incision?
So we have to give on the steepest meridian.
Steepest meridian. The knife used was diamond knife or any knife to
So
keep the cut?
in R we used a specific knife by Mani,
Acha, there is a
which
specific.
gives the diamond knife is actually costly. It is like 25.
Okay,
to
when we used to
30,000.
be radial keratotomy,
Yes,
there
yes.
we used to do a.
So this is only 600 or 650, and it can be used in 5 to 7 cases.
चलो, thank you. आप नाम क्या है इसमें, कहाँ पर है दिमाग? आपका अच्छा ये प्रेजेंट है, बाकी का एब्सेंट लगा दो। कुमार डॉक्टर एब्सेंट है, शिवानी एब्सेंट। हाँ अच्छा ये तो प्रेजेंट है, प्रेजेंट शुरू हाँ नहीं है ना। अंकिता एब्सेंट। अच्छा अंकिता प्रेजेंट, हाँ यही मैं देता। अंकिता मान ठीक है। सुरभि एब्सेंट, अभिषेक एब्सेंट, अंकिता प्रेजेंट। अच्छा ठीक है एब्सेंट। चलो अंकिता होगी ठीक है।
Good evening, sir. My study is to study the white-to-white measurements using 4 devices and how to determine the size of ICL by measuring the post-operative wall. So the STAR ICL V4 was first FDA approved in 2005 and historic version was approved in 2018. The current version is ICL V4C, which comes with a central 0.36 mm hole which allows the aqueous to circulate naturally and therefore it reduces the risk of percolate block. So for ICL sizing, several parameters have been investigated like ciliary sulcus to sulcus distance, crystalline length rise, but white to white remains the easiest and most widely used. The ICL comes in 4 different sizes for myopia. So the background of the study was that white to white measurement is an important step in ICL sizing and it is also required by the online calculator of the manufacturer, which in turn dictates the wall. But different devices provide different white to white measurements, so it's very difficult to choose which value we have to use. So our study was to obtain white to white measurements from pentacam, eye trace, lens star and digital caliper, and its effect in determining the correct size of ICL by measuring the post-operative wall size using OCT. So it was a retrospective cross-sectional study where we used 98 eyes of myopic patients who underwent ICL implantation. After thorough pre-op assessment, white to white was measured on different devices and compared with the caliper white to white. The caliper white to white served as the baseline. Measurement obtained by the caliper was selected as the final selection for ICL sizing. Post-operative walt was measured using OCT after 1 month. So the result of the study was that mean white to white measurement varied significantly between these devices. The range of digital caliper white to white varied from 10.8 to 12.6 mm with the mean of 11.6 mm, and it was most comparable with pentacam mean white to white of 11.84 mm. While the lens star had the largest mean white to white of 12.05 mm and iTrace had the smallest mean white to white of 11.29 mm. In pairwise comparison also we can see that the mean difference was the smallest between the pentacam and the caliper and the largest between the caliper and the lens star. So coming to the bland ointment analysis between the pentacam and caliper on white to white, it shows a mean difference of 0.18 mm and limits of agreement of minus 0.46 and a high correlation coefficient of 0.693. This implies a very good agreement. But between caliper versus lens star, it shows a very high correlation of 0.807 but a very high systemic bias of minus 0.38. Again, among the 3 pairwise comparison, we can see that the pentacam and the caliper had the lowest systemic bias of only 0.18 and had most of the data points within the limits of agreement. In our study, 65% of eyes achieved walt within 0.25 to 0.75 mm in 1 month, and approximately 10% eyes achieved walt less than 0.25 mm and 25% eyes achieved walt of more than 0.75 mm in a month. The shallowest walt was 0.14 mm and 0.24 mm and the deepest walt was 1.31 mm. So to determine accurate ICL sizing, various near parameters have been studied like sulcus to sulcus using UBM, crystalline lens rise using ASOCT, but manual white to white using digital caliper still remains the gold standard. The major dilemma faced is which one of these devices can provide data that would result in ideal post-operative walt. In the beginning, when STAR recommended white to white using OpScan 2 for ICL sizing, but it is no longer available, so the newer devices are being used now. Previous study similar to ours was by Bomiston et al. They used caliper Opscan 2 and oil master 500 and found that the measurements by caliper was examiner dependent and it varied significantly. They also observed that mean white to white with iron master was higher than Opscan white to white. In our study, the pentagram white to white yielded an ICL size similar to caliper in almost 86.66% of eyes, while the Lenstar and iTrace yielded an ICL similar in 71% and 66% eyes respectively. Post-operatively, the caliper and the pentagram white to white yielded higher percentage of eyes with desired word. Purely using Lenstar or iTrace data would likely recommend a larger or smaller ICL size, which may lead to undesirable high and small walls respectively. So to conclude, white to white measured by the 4 devices varied significantly, which led us to conclude that white to white measurements from these devices were not interchangeable. We tried to determine which of these devices had the highest likelihood of measuring white to white that can calculate ICL size, which would result in desired word range. If we consider manual measurement by digital caliper as the baseline, then white to white measured by pentacam comes closest to it as compared to the other newer devices to calculate ICL size, and this can achieve desired post-operative word.
So to put a ICL, which method you are using?
Sir, we are using digital caliper, sir, but nowadays we are correlating it with pentacam white to white.
Pentacam is the corporate.
No sir, pentacam is just to see that how much how much difference is there. But we always go with the manual white to white. But because it varies, like if I do or if sir does, so the measurement can differ. And even for the slightest change, the size of the ICL change. Like for 12.1 the size is different. For 12.2 the size is different. So we have to get the baseline. So like it's like measure. But the pentacam one, we do rely. Mostly we rely on the manual measurements of pentacam. Like if there is a function, if we go to the iris configuration and then manually we can measure the white to white. So that is better than the automatic one.
2 eyes के uses बताना, वैसे पूछ रहा हूँ.
किसका सर?
2 eyes के uses.
2 eyes is?
मतलब we have 2 eyes क्या? इसके uses क्या क्या?
Sir, I didn't.
हाँ बताओ, तुम बताओ.
I did not hear.
अरे we have 2 eyes ने.
हाँ सर,
तो उसके uses क्या क्या?
अच्छा कंपनी हाँ. So fusion के लिए help करता है.
Fusion के लिए.
फिर उसके बाद to see for the temporal and the nasal part.
फिर
coordination के लिए, synopsis के लिए, near vision के लिए दोनों आपकी जरूरत पड़ती है.
और
सर fusion में mean
और
peripheral distance
और
brain के अलग उसमें हो जाता है सर.
और
vision तो नहीं, मतलब एक आँख से भी दिख जाता है, but peripherally
spiritually तीसरी आँख खोलने के
तो
लिए.
तीसरी आँख भी है.
जब 2 आँख बंद करते तो एनर्जी यहाँ करती
तीन
है.
आँख, तीसरी आँख.
थर्ड आई से क्या फायदा है कि 20 साल बाद जो रिसर्च होने वाली है ना,
हाँ जी
वो आप डिटेक्ट कर सकते हो. जिसका टाइम ट्रैक मेथड,
Okay.
उसको कहते हैं कॉस्मिक इंटेलिजेंस. क्या कहते हैं?
Cosmic intelligence.
पढ़ा है कभी?
सर like meditation में तो पढ़ा है.
हाँ, कॉस्मिक इंटेलिजेंस होती है. ये 2 आँखों का यूज तब तक है जब तक हमारी तीसरी आँख खुल जाती है. अगर इस जन्म में नहीं खुली तो नेक्स्ट बर्थ में तो जन्म लेते रहोगे, क्योंकि इस संसार से जाने के लिए तीसरी आँख का यूज है, हाई लेवल पे जाने के लिए. स्पिरिचुअली ऋषिकेश है ना साहब,
हाँ जी सर.
ठीक है ना. तो ऋषि कौन होते हैं? जिनकी तीसरी आँख खुली होती है, जो तीसरी आँख खोलने के लिए बैठे हैं. ठीक है, चलो आज के लिए इतना काफी है. यही ऑब्जेक्टिव है और कुछ नहीं है, बाकी मिथ्या. ये बंद कर देना, नॉलेज चली जाएगी तो काम की.